right. So I'm going to just review what's out there, and then I'll talk about the clinical trials that are, for the most part, completed, and we're waiting for data or ongoing clinical trials. And so all the trials actually have been updated in the last 6 months or so in the literature in terms of a little bit better long-term outcome for the patients in the adjuvant Herceptin Trastuzumab trials. So just to review what the trials were, this is 9831. You're all familiar with this. And this was the trial of early breast cancer, HER2 positive, and patients all got AC followed by weekly paclitaxel with concurrent trastuzumab or trastuzumab following the paclitaxel. And then the B31, which was being run concurrently, it was AC followed by paclitaxel. For the most part, it was being given every 3 weeks, although into the trial, they began to, you had the option of taking the trastuzumab to weekly. So just head-to-head, 2,000 women in that trial. And as you know, the joint analysis combined the arms of this trial for statistical analysis. So although the patient populations are a little bit differently, they combined the AC followed by paclitaxel arms with and without the trastuzumab, and they pulled out the group where it was sequential, AC followed by paclitaxel followed by trastuzumab, because that group is doing a little bit worse. And then the BCIRG trial has also now been published and updated, which are, again, HER2 positive, high-risk lymph node negative or lymph node positive, AC followed by docetaxel, AC followed by docetaxel with concurrent trastuzumab or the TCH regimen. So what are the differences and similarities among all these trials? All of them included lymph node positive patients, and the BCIRG trial and started with the lymph node negative, and then eventually both of the other intergroup trials added lymph node negative who are high risk. And everybody got 52 weeks of trastuzumab. The BCIRG trial gave it weekly during the chemotherapy and then went to every 3 weeks afterwards. The HERA trial, which I'm not going to present today because I think we're waiting on the 1 versus 2 year data, and that's still not presented, which makes it a little bit worrisome about whether they're going to see a difference at the 2 years since nothing's happened yet. And then there were a little bit differences in the cutoff fraction for ejection fraction for these trials. So the newest update that was published in JCO in the last 6 months or so by Edith Perez, again, the combined intergroup and NSABP trials. These are the curves from the JCO now showing out at 5 years, but at 4 years you can see the event-free survival. It continues to be statistically significant, so it's holding up with at least a 50% improvement in outcome by the addition of trastuzumab, and survival. The numbers are really narrow, but with a large number of patients in this trial, it's a relative 40% improvement in survival. And I don't think any of us are thinking about going backwards. We're just tweaking at this point what our adjuvant regimen is. And so just looking at risk factors for the risk of recurrence, clearly women who had 10 positive lymph nodes had a worse outcome than those in the trials with no positive lymph nodes. There is a suggestion that every 3 week paclitaxel had a worse outcome when they looked at that, so a 40% worse outcome compared to the women who got the weekly paclitaxel. And tumor size was also predictive, but the strongest predictor here was whether you got trastuzumab or not. They did look at control versus trastuzumab around the issue of age. There was no age group that did not benefit from the trastuzumab. For the patients with 0 positive lymph nodes from the joint analysis, really there are so few that they did not see the statistical benefit of the trastuzumab, but I personally think that that's just a numbers thing. And the patients who were both ER positive and ER negative, both groups benefited from the trastuzumab, no issues with tumor size, and all tumor grades benefited as well. So these forest plots are hard because the wide confidence intervals they had around the lymph node negative population, where there were only 280 from the combined group, which is why we've just got statistical problems. Not problems, but I just think it's a group we shouldn't even be looking at for this randomized trial. There's just too few patients. But on the forest plot, every group essentially benefited from the trastuzumab. And then they looked at the events that occurred in these women. The blue are the women on trastuzumab. trastuzumab, the yellow women who did not get trastuzumab. And although they're mirroring each other, just really the substantial risk within the first 3 years of having a breast cancer event, for the most part metastatic cancer, so high on the women who did not get trastuzumab, and then sort of the rapid follow-off there. So typical of our high-risk cancers, the first 3 years are the most critical for recurrences. And then the issue of cardiac events. In fact, although all the trials presented the cardiac information from the trials, there was an independent evaluation of the cardiac issues that occurred from all these trials to really get a much more independent cardiology point of view when they really looked at the data. This is hard to see, but they really looked at risk factors for the development of a cardiac risk, and so it was issues around age and other medical problems, height and weight, ejection fraction prior to starting therapy, ejection fraction after they got an anthracycline, that sort of thing. And then they had a multivariate analysis that found that there were 3 things that really were predictive of developing a cardiac event, whether you got trastuzumab or not. Your age, under or over the age of 50, and where your ejection fraction was prior, within 28 days prior to the event. So these were able to be predictive. Then they looked at whether you had 1, 2, or 3 of the risk factors, 0, 1, or 2 of these risk factors. And if you had 2 of these risk factors going into starting the trastuzumab, you doubled your risk of developing, you can see that the hazard ratio, you doubled your risk essentially of developing a cardiac effect. So that there are algorithms that are out there, and this JCO article is something you may want to look at to understand the risk if that's a driver for you. With regards to the BCIRG trial, that was finally published in October 2011. You're well familiar with this trial of over 3,000 women, lymph node positive or high-risk lymph node negative, with the non-anthracycline TCH arm. When you look at the characteristics of the patients, you can see that almost 30% of the patients on this trial are actually lymph node negative as opposed to the other trials. And then variable issues around tumor size, and about half the patients were hormone receptor positive. As the data are presented, you should know that, and I'm sure you're aware, but I'll just make the point again, the trial is only powered to compare the trastuzumab arms to the non-trastuzumab arm. The trial is not powered to compare the 2 trastuzumab arms. So although a lot of people are talking about the 2 arms compared to one another, that's not how this trial is run. And so people who are critical of the TCH, and we'll discuss why they have criticism of it, are concerned because it wasn't powered to do a comparison. There's a possibility that TCH is inferior. So let's just look at these numbers. These are the disease-free survivals now at 5 years from the trial. It's 84% disease-free in the AC, followed by TH. TCH is 81%, and then no trastuzumab is 75%. So that we'll get to this point, but there is that numerical 3% difference between the TCH and AC followed by T, although you're not supposed to look at that comparison. They again looked at the topoisomerase 2 data, and just as a review, topo2 sits on chromosome 17, and in some percentage of patients, perhaps a third of patients, it is also co-amplified with the HER2. And they did present their data on patients who do not have topo2 amplification, that you saw the same benefit of the trastuzumab arms, similar to one another compared to the non-trastuzumab arm, although you'll see that there's a numerical 3% difference between the top 2 arms. And if they are topo2 amplified, the use of an anthracycline brings their benefit up to the same use as a trastuzumab patient, so that really there's no differences among those 3 arms. There are other trials that suggest that the topo2 amplification has no impact here, that anthracycline does not impact on those patients. So I'm not sure why you would not use trastuzumab and substitute an anthracycline in instead of it. That wouldn't make sense to me. And there's still more cardiac toxicity with an anthracycline than there is trastuzumab. And then overall survival, you can see at 5 years is 92% versus 91 versus 87%. Among the arms. So there's definitely the non-trastuzumab arm is inferior to both of the other arms. When you look at the forest plot, these are the ACTH versus the without trastuzumab arm. The forest plot clearly shows in every group that it's better to give the trastuzumab. When you look at the TCH versus ACT, it falls apart a little bit. There are some of these prognostic factors that do seem to cross one. And then there are just the issue of dividing lymph node status, so those that are lymph node negative versus positive. And again, you're only supposed to compare the non-trastuzumab to the other two arms. And when they looked at 4 or more positive lymph nodes, however, where you would think that if TCH really is inferior, you'd really pick it up here. And in fact, this is the strongest showing for TCH in the highest risk group or 4 or more positive lymph nodes, where the 5-year disease-free survival is 72 versus 73% in the anthracycline arm and 61% without trastuzumab. So here are the total number of events as they were published for all events. So breast cancer events, distant metastases events. But when you look at grade 3 or 4, so symptomatic congestive heart failure, there were 7 in the ACT, 4 in the TCH, and 21 in the trastuzumab when those patients got anthracycline. For acute leukemia, interestingly, there are 6 in the non-trastuzumab arm. There's 1 in the AC with the trastuzumab. TCH, it's 1, but the acute leukemia occurred in a patient who developed metastatic disease and subsequent anthracycline, and after that she developed acute leukemia. So probably not related to the TCH drugs. So as Dr. Slayman and his authors are trying to rally you around not using an anthracycline, they're really pointing to this toxicity data to say there are issues of relapse from breast cancer, there are issues of permanent toxicities for the patient. And they looked at cardiac risk factors as well from their clinical trials. Left-sided radiation therapy, no difference among the arms. Really, they really were not able to pull out a group that was higher risk of developing congestive heart failure among the different risk factors you'd think about. And again, symptomatic congestive heart failure now is being reported in 0.7%, 2%, and 0.4% for the patients in the trial. And Dr. Slayman has, again, tried to tout this over and over again, that even though you may recover some of your ejection fraction after receiving anthracycline and trastuzumab, you don't get back to baseline, whereas on the TCH arm, even if you have a drop, you come back to baseline. What are the long-term effects on a cured patient for the heart if you drop the ejection fraction by 4 points or 8 points permanently? And I think that's not known. So in response to this, there was a publication from the group at MD Anderson around the issue about over the last 10 years how we've been slowly getting away from anthracyclines for breast cancer across the board. And I think Dr. Giordano wrote that article, and this is an editorial in response to the paper, which was not based on HER2 positive, but it was quite a smackback in terms of the trastuzumab. So Hal Burstein and many, very well-respected and well-known breast cancer oncologists are part of this, really questioning whether we should drop anthracyclines in the adjuvant setting in the HER2-positive patients. And I'll just summarize the points of this editorial, which you can go read. It's in the last month or so at JCO. They suggest TCH is not what we should be using as a standard for adjuvant therapy of HER2-positive breast cancer, that the BCIRG trial was not powered to show equivalence or non-inferiority. You weren't supposed to compare the two arms to one another, but numerically, no matter how you look at it, there are fewer recurrences and deaths in the ACTH versus the TCH trial. And there is a persistent 3% improvement total 3% improvement in disease-free survival following ACTH versus TCH at 5 years. So that group will strongly encourage you to use anthracyclines and anthracycline-based trastuzumab regimens as the mainstay of therapy for patients with HER2-positive cancers that you think are at high enough risk, and TCH should only be considered for women with low-risk HER2-positive tumors or some reason to avoid anthracyclines. Just the issue about HER2 testing is becoming problematic for us. It's always been problematic, but there are issues from the 9831 trial that patients who went into the trial were originally HER2 positive at their institution, but on central testing appear to be HER2 negative, except when you look at the 5-year disease-free survival, even in the HER2 negative patients, there appears to be a statistically significant benefit from being randomized to trastuzumab, even though on central testing they're HER2 negative. And so that was seen both in the overview of the whole group on 9831 and in B31. So there's a trending of suggesting any positivity for HER2, even on central testing turning negative, those patients may be benefiting from trastuzumab, although we don't understand the mechanism. So this is the ongoing NSABP B47 trial, which is looking at women with lymph node positive or high risk lymph node negative breast cancer who are HER2 low. So by IHC, they're testing 1+ or 2+. By FISH, they're negative. And they are being randomized to chemotherapy with or without trastuzumab. For you. So this is an ongoing trial trying to answer low expression of HER2 positivity, whether there's a benefit from trastuzumab in a randomized clinical trial. And then finally, the issue of small cancers. Eric Weiner at ASCO did this lovely presentation, and this is essentially from his presentation about small cancers. None of the patients who are 1 centimeter or less were included in any of the adjuvant trials, and we don't really know the benefit of trastuzumab for these patients. MD Anderson several years ago published a retrospective look on 965 patients who had T1A or T1B lymph node negative cancers who got no adjuvant chemotherapy.
They exist.
Excuse me?
They exist.
They exist, right. Well, that they got no adjuvant chemo, it's amazing at MD Anderson. So 10%, that's her point, 10% of these patients were HER2 positive. So now we're down to 90-some patients. So the median follow-up is really long on these patients, but the 5-year disease-free survival for those patients 1 centimeter or less HER2 positive was 77%, and distant recurrence-free survival for the HER2 positive was 84%, no chemotherapy. And these are the curves, especially in the hormone receptor positive. You can really see these curves separating out for the HER2 positives have a worse outcome. The Kaisers looked at this also. They have 237 cases of HER2 positive T1A or B with a median follow-up of about 6 years. And when they look at the invasive distant recurrence, it's 9% in the T1Bs, 3.5% in the T1As. So there is a risk of developing distant metastases even in these small tumors, although none of them are in the trials. So what are the trials? This is a closed trials analysis, a Dana-Farber trial for women who were thought to be low risk, although women could have cancers up to 3 centimeters in size, lymph node negative. I'm not sure that's low risk. And they were enrolled in a trial of weekly paclitaxel with trastuzumab followed by a year of trastuzumab. That data is not yet presented. But when you look at who's on the trial, only 19% of the women on this trial are T1A or smaller. 30%, however, are T1B. So we might be able to get at some of this data, but it is just a phase 2 trial. So what do we do outside of a trial for small tumors? You could use ACTH, you could use TCH. They seem like they're fairly toxic with a relatively low risk of metastatic disease. Some people are using AC followed by trastuzumab. Some people are using the US Oncology TC with the C being Cytoxan and subsequent to trastuzumab. You could use the weekly regimen. You could use trastuzumab alone with or without hormone therapy, or just do nothing and hope that you're one of those have a patient who's a 90% chance that they won't recur. So the last two are the pending clinical trials that are completed. This is the BETH trial. So this is, again, high risk, lymph node negative or lymph node positive. They were randomized to TCH with or without bevacizumab. That trial's been closed for over a year, so we're waiting for data from that trial. And then the ALTO trial, 8,300 women, HER2 positive, randomized to paclitaxel AC, followed by paclitaxel weekly with trastuzumab, with or without lapatinib, and we all know that the lapatinib-only arm has been closed for inferiority here. So I think this will really drive whether we begin to use two anti-HER2 agents in the adjuvant setting. And my conclusion is that we're going to always continue to use trastuzumab. I think the interesting trials right now are around the issue for low-expressing HER2, and I would not give them trastuzumab, however, outside of a clinical trial. Okay, thank you.
Thank you, Christy. No. Questions at the end. Yeah.